A great opportunity to welcome our senior chairpersons for the session, Dr. B.K. Nayak, who is currently the president of GSI, and Dr. Madhu Bhadoria, who is heading the Sitapur Eye Hospital, the glaucoma division. Dr. Bhagwat Nayak is at AIMS Bhubaneswar, faculty, glaucoma. And we are waiting for another chairperson. So we'll start, sir, with your permission, please.
Yeah, we can start. So, Dr. Manish.
So, pleasure to invite Dr. Manish Singh for the first talk, who will be talking on right way to start and escalate therapy for 7 minutes. Please, audiovisual can set the timer to 7 minutes. Dr. Manish is currently the treasurer of GSI and the local boy here. Dr. Manish, all yours.
Thank you, sir, for the opportunity. And so I'll be speaking on the right way to start and escalate therapy. Just 7 minutes, so I'll just highlight 7 key points. One very important point, especially for the young practitioners, is you diagnose before treating. So very important thing, what happens, in a busy glaucoma practice, what happens, you are mainly treating the intraocular pressure. So pressure is 24, you add medicine, you have reached your target, you are happy. So sometimes it happens you're treating the intraocular pressure more than the glaucoma. So especially, it's very important you write the diagnosis. When you write the diagnosis of, say, a secondary glaucoma, it makes you think, what is the cause of glaucoma? Have I taken the history of steroid? Have I looked into angle recession? Whether I've seen the pseudoexfoliation? When you write diagnosis of primary open-angle glaucoma, it makes you think whether I've done a gonioscopy or not. So always write your diagnosis before you start treating your patient. Also very important, before setting the target pressure, try to do a risk profiling for your patient. Look into the life expectancy, what is the level of damage, mild, moderate, severe, what are other associated risk factors, whether there are any disc hemorrhages or not, what is the status of the other eye. Based on that, you can get an idea whether it's a high-risk patient or a moderate or a low-risk patient. And accordingly, when you're setting your target intraocular pressure, if suppose it's advanced glaucoma with long life expectancy, and there are associated risk factor and damage occurring at low IP, definitely you'll be setting a much lower target intraocular pressure. When we were postgraduates, this is the chart we used to use. Even now, this is very relevant. When you're starting your treatment in advanced glaucoma, a 40% reduction. In moderate to mild glaucoma, 30% reduction is generally what we aim at. But this is just for starting the treatment. Over time, based on the rate of progression, whether the patient is stable or not, you have to keep reassessing your target intraocular pressure. So we always have to remember target IOP is a range and it's a dynamic value. You have to keep resetting every 4 to 6 months based on the response of your therapy. Mostly worldwide, prostaglandins have become the drug of choice. In India, beta blockers are still very popular. But then when we are setting a target, we have to see which drug can take me to my target intraocular pressure. And prostaglandins definitely are the best options because they give you the best IP control, the least systemic side effect, and they give you a 24-hour IP control. But India, if you see the most recent 2023 data also, the most two popular drugs in India are the timolol and the brimonidine and timolol combination. So IP reduction with prostaglandins are the best. Now, when to switch and when to add. And EGS has given a very simplified guideline. Whenever you're starting medication, if the IP lowering is less than 15%, we assume that the patient is a non-responder. We try a different class of medication. But if the IP reduction is more than 15%, we are not able to reach our target IOP, we'll add a medication. And whenever using 2 or more medication, try to use combination drugs, which definitely makes life simple for the patient. The cost is less, the preservative exposure is less. You're getting an additional therapy also, and definitely it gives you a more easy regime for the patient to follow. Apart from prostaglandin, the best adjuncts we have are the carbonic anhydrase inhibitors, the brimonidine, beta blocker, and now we also have the ROCK inhibitor. There are various studies highlighting the efficacy of each drug, but overall the consensus is anything between 10 to 15% of extra IP reduction you can get with an adjunct. All of them have their advantages and disadvantages. Beta blocker definitely is more cost effective. They have higher systemic side effect. The efficacy is less at night, but the IP reduction is good at par with any other adjunct. If you have a patient where you are suspecting ischemic factor, you're looking at disc hemorrhages, there are other ischemic factors, patient has a poor cardiovascular profile, these patients, a carbonic anhydrase inhibitor can be a better option than a beta blocker. Brimonidine is useful in non-mutational glaucoma patient as an adjunct. You are not only bothered with intraocular pressure, you are also looking into a neuroprotection. Definitely a brimonidine can be a good option. A ROCK inhibitor can be used in all types of glaucoma, especially in non-mutational glaucoma also they are useful. They are supposed to be both vascular and neuroprotective. However, they come with some newer complications. The hyperemia rate is very high. But at the same time, you have other risk factors like subconjunctival hemorrhages, and sometimes you can develop these reticular corneal edema. Also in a busy practice, you need to classify your patient, which patient need extra attention, which patient we can be seeing as a routine case. For example, you're seeing say 60, 70 glaucoma patients in a day. What we always do, I'll highlight in a file which patient needs a close follow-up, so I'll put a star mark. So you classify patient in OPD into safe and unsafe zone, the way highlighted by Dr. Anders Heil. So if suppose I've got a young patient with long life expectancy with moderate to advanced glaucoma, I'll be extra careful because these are the patients who have a high risk of getting blind over time. On the other hand, I've got a very old patient with early glaucoma, I'll be probably be little easy with that patient. Also, the recommendation is that in first 2 years, try to do 6 fields. Most of us do visual fields every 4 to 6 months. So doing 6 fields in 2 years is actually not that difficult. So if you're doing fields every 4 months, you can do 6 fields in 2 years, which will help you to get a VFI plot and see the rate of progression. If the rate of progression is less than 1.5 and you can see the patient is maintaining his vision, you can just keep the patient under treatment. If it's a steep rate of progression, the vision is going down. In this case, you need to consider stepping up a treatment. But it's a very steep rate of treatment, more than 2 decibel per day. Per year, you need to relook at the patient. Maybe you might have missed a closed angle, you might have missed a pseudoexfoliation, maybe there is some serious issue with compliance of the patient. So treat the patient as a new patient, relook at the patient again. But coming to maximum medical therapy, mostly we use 2 bottles or 3 drops in a day, so something like a brimonidine with a brinzolamide with a prostaglandin timolol combination can give you 3 drops per day and 4 medication. But now with the triple drug available and even the prostaglandin with ROCK inhibitor in the pipeline, you may get 5 medications with just 3 drops per day. So just to summarize, just key points, always write your diagnosis before treating your patient, do a risk profiling, then you can set a target intraocular pressure better. Always start with the monotherapy. Now with the triple drug coming up, a lot of time there's a temptation to start 3 drugs. Never do that. Always start with single drug, see the response, and then you add medication. Switching or adding, we've already discussed. Combination drug wherever possible. And if the patient is progressing on maximum medical therapy, consider going for SLT or a surgery. Thank you.
So thank you, Dr. Manish, for giving a good guideline for starting treatment. And it's really, these are all basics and we must follow to the core. And one point he said that because of the combination of 3 medicine which has been launched now in the market, so never start with the first thing with the triple combination unless you have tried all 3 and which is all required. The next I'll request Dr. Purvi Bhagat, who is going to talk to us about drug interactions.
Good afternoon, everybody. I'll be talking on drug interactions and side effects of the anti-glaucoma drugs. No financial interests to be disclosed with respect to this presentation. So when we talk about side effects, basically what we know as drug reactions or what is popularly known as adverse drug reactions or ADRs, there are 3 main culprits. One can be the active ingredient or the drug itself, or it could be the preservative. Most of the drugs which are now notorious for side effects are because of the benzalkonium chloride, or it could be the overall composition, more significantly the pH of the drug. There are 4 types of reactions that can happen. One is the ocular ADRs in response to topical ocular drugs, which are usually very easy to recognize. Or it could be a systemic ADR in response to a topical ocular drug, mainly because of the systemic absorption through the nasal mucosa. Third, it could be a systemic ADR in response to a systemic drug. Again, these are usually easy to recognize. The 4th category is a little difficult to diagnose, and for this you need a complete medical history and knowledge of the pharmacokinetics and pharmacology of the drug. That is the ocular ADRs which respond to a systemic drug. Here these drugs are not basically anti-glaucoma drugs, but they can often mess with your diagnosis of glaucoma, the management, and they can actually cause glaucoma. So these are the different types of side effects that we see. A very common periocular pigmentation that we see with PG analogs, and you can understand the concern it may cause, especially if it is a unilateral, if it is in females or young individuals. A characteristic allergic conjunctivitis which happens with brimonidine, it can happen at any point of time within 1 week of starting the treatment or even after a year. The patients will come with complaints of itching and foreign body sensation, and you should never fail to evert the lead, and you will see this characteristic allergic conjunctivitis. Again, a significant hyperemia. Earlier, it used to be caused by the bimetoprost higher concentration, and now it is so very commonly seen with the Rho kinase inhibitors. A periocular dermatitis, again notoriously caused by brimonidine, but can also be caused by the topical CAIs. Another case of polypharmacy, you can see the significant amount of periocular pigmentation and the dermatitis and lid thickening and edema that is there. Subconjunctival hemorrhages, which are not uncommon with the Rho kinase inhibitors, and the very popular reticular honeycomb type of a corneal edema, which is there with netarsodil. And the patients will come to you with a decrease in vision, and you can just check when you see this type of an edema that the patient would definitely be on netarsodil. Again, these are cases of advanced dermatitis. You can see because of the constant rubbing that happens, the itching, the watering, the patients keep on rubbing their lower lids, because of which the punctal eversion and even a medial ectropion has started. Another case of punctal eversion, and you can see the lower lid edema, which is there because of brimonidine. And on omission of the drug, you can see how that entire side effect has reversed. Another case, this was just last week we encountered, this is erythema multiforme minor, which is because of use of acetazolamide. The major form, what we popularly know as the SJ syndrome. So this is in response to acetazolamide. There is an endless list of drug interactions and side effects which happen with the anti-glaucoma drug, and none of the anti-glaucoma drugs, unfortunately, is totally free from side effects. The PG analogs, apart from the topical effects, they can cause headache or flu-like symptoms. Timolol, of course, we know its effect on the respiratory system, on the cardiac system. It can mask the effects of hypoglycemia and brittle diabetes. It can cause hyperlipidemia and fatigue. Brimonidine, it causes CNS depression and even mood changes, because of which sometimes the patients can undergo unnecessary psychiatric and neurological investigations and MRI and whatnot. But all we actually just need to do is be aware and omit the drug. And if a patient is sensitive to brimonidine, it often predisposes to allergy from other drugs. Topical CAIs and acetazolamide, we know about the SJ syndrome. And pilocarpine, systemically, it can cause abdominal cramps, which in acute angle closure glaucoma can sometimes mimic acute abdomen because of the cramps and nausea and vomiting that the patient has. And glycerol and mannitol, of course, we know glycerol can cause nausea, vomiting. Mannitol can have effects on the respiratory system, on the CNS, on the cardiac system, and on the renal system, especially in compromised patients. The tolerability of drugs overall decreases with increasing age of the patient. More the number of drugs and more the number of bottles the patient is using, more the duration of therapy, and with the presence of benzalkonium chloride in the composition. These are again cases of significant BAK sensitivity. Both these cases, you can see the significant amount of edema and periocular dermatitis that is there. No matter what the patient used to instill, the dermatitis would just be there, or it would keep on increasing. And what we ultimately figured out, it was not the drugs which were causing the reaction, it was BAK. And simply on the omission of BAK containing drugs and transferring the regime to preservative-free formulations, you can see the recovery the patients have had. At our college, we have the Pharmacovigilance Program of India Nodal Center. So they encourage all the departments to report the ADRs to them. So this is an evaluation of 2023 of the ophthalmic ADRs. So out of the total 2,049 ADRs that were reported to the Nodal Center, 59 were from ophthalmology. And of course, 59 are the reported. There would be more which were unreported. Males more commonly affected, elderly more commonly affected. Presentation very variable. The most common ADR was redness, itching, and allergic dermatitis. And the commonest ophthalmic drug group which was involved was anti-glaucoma drugs. And of these, brimonidine being the most notorious, followed by the topical CIs, netarsodil, and then timolol. So what is the impact of all these side effects and reactions? Most of them are innocuous and reversible after omission, but sometimes fatal ADRs like the SJ syndrome, sometimes status asthmaticus from timolol have also been reported. But from all those images, we can figure out that even a smallest amount of impairment can have a substantial impact on the patient's quality of life. It is the most common reason for non-compliance, and any effect on the ocular surface is likely to affect the outcomes of the surgery also in these cases. So it is very, very important to early detect these ADRs, be aware of what ADR can happen, not to ignore the symptoms and signs, and keep our focus beyond glaucoma and beyond the IOP and DIS also on all the symptoms. Immediate withdrawal of the offending agent is necessary, and a prompt clinical management to treat the ADR and to prevent complications is necessary. Beyond that, it is also important to report these ADRs, not only to the pharmacovigilance department. They have their own portal where you can report all these ADRs. but also our own AIS has an adverse event reporting committee, wherein any unusual, unknown, or clusters of EDRs, if you see, you can report to them. So at the end, it is important to recognize the side effects, investigate them, withdraw the drug, act on it, report it, and most importantly, prevent the recurrence. Thank you.
Thank you, Purvi, for a very nice presentation and showing all your own pictures in a very pictorial way. People will remember them. Now I'll request Dr. Sachin to talk about glaucoma in pregnancy.
So I start by thanking the AIOS and Dr. Tanuj sir for the opportunity. So just as an extension, we'll just see the drugs that we need to be careful of in this subset of population. What we need to know that about this topic is that nowadays we have an older age of at conception, rising infertility and incidence of around 2 to 3% of glaucoma in pregnant women above the age of 40. Although the percentage in ages less than that is minuscule, the consequences of a miscalculation can result in lifelong morbidity of child, complicating the quality of life years. So the categories of patients that we may face in this are the glaucoma patients wanting pregnancy, glaucoma patients presenting with pregnancy, glaucoma with relentless progression in pregnancy, and glaucoma in breastfeeding. So the risk profile of each class of drugs actually changes with time of gestation and breastfeeding, so not to miss the transition is very important. So the major diagnoses that we deal with are usually congenital and developmental glaucomas, juvenile glaucomas, secondary ones with steroid, pigmentary, GRA associated, uveitic and post-pediatric cataract surgery, and also some primary glaucomas considering the older subset of population. The denominators that we consider during this treatment are the stage of pregnancy, stage of disease, that is glaucomatous damage and the rate of change, specific risk factors and allergies, FDA classification and safety profile of the drugs basis published reports and animal studies. And remember that no medicine in this is the best medicine and the least medicine is the second best. So why this is a special situation is that you have the pregnant patients have a lower IOP than the general population, contributed by the lower episcleral venous pressure. But what you have to remember is that majority of these changes start at the end of the first trimester and fade out after weeks of childbirth. So the major part of the first trimester is not covered by this physiological pressure lowering. Intrapartum pressure changes are not very significant to be of any consequence. And whereas most of these glaucomas that present in this age group usually are very high pressure glaucomas, the physiological drop might not be of any consequence. Now, as far as pregnancy in glaucoma patients are concerned, this is a topic that prevents clinical trials because of ethical considerations. So all the information that is available to us are available on reports case series. The reports of IOP changes are mixed, with decrease in the second trimester being the commonest and variable fluctuations with some increases in the third trimester that have been noted. General IOP reduction early on is usual and maximum documented is around 24% in the late second and early third trimester. So active surveillance for all glaucoma with very high IOP is very advisable because these are the patients who will progress. So the most important subset of patients I would say is the glaucoma patients wanting pregnancy. So if the patient is already on the radar, this is the time to act because major preventive actions can be taken and plans can be put in place. Counseling and planning for future pregnancy is imperative at opportunistic or regular visits. Medications can be minimized, adjusted as per the triage, FDA recommendations to reduce the fetal adverse events basis current knowledge. Trial of laser procedures, performance of anticipated surgeries can be evaluated and appropriate counseling can be done for this subset of patients, preventing major handicaps. Now, when the patient presents with pregnancy is the major challenge, and our options are usually a multidisciplinary approach between the radiologist, obstetrician, and glaucoma specialist. The medications, laser, and surgery are the options as we all know and have seen. The considerations are stage of pregnancy, stage of glaucoma, and risk-benefit ratio. Needless to say that malformation scans when the patients presents to you in early first trimester are very, very important for the further counseling of such patients. Now, the medications are classified by the FDA into A and X category, where A is safe and X is teratogenic. Unfortunately, none of the glaucoma medications fall into the A category. Some fall into B, that is like brimonidine, B for brimonidine, and others fall into category C and mitomycin into X. So here, although brimonidine is safe, aproclonidine is still categorized in category C, and it is brimonidine is labeled as safe in all stages of pregnancy, but not in breastfeeding. It can cause apnea and respiratory depression in infant. That is where the transition takes place, and you have to be careful in case the patient is on brimonidine pregnancy. As far as the beta blockers are concerned, a category C drug, it can cause IUGRs, fetal bradycardia, and low Apgars with systemic beta blockade. And you have to use with abundant caution in pregnancy, especially in low doses of 0.25%, avoiding the first trimester and the peripartum period. Punctal occlusion has to be demonstrated and occlusion has to be stressed for such patients to minimize the chances of a problem. Caution and monitoring in breastfeeding is also essential. As far as carbonic anhydrase inhibitors are concerned, oral and topical, the category C drugs, major trials which have been reported have not shown too many side effects of carbonic anhydrase inhibitors except in the first trimester, and also some fetal limb anomalies in animal studies. So the general guideline is to avoid them in the first trimester and use with caution in the later stages. High doses can be avoided peripartum to prevent electrolyte imbalances in the child. They are deemed safe by American Association of Pediatrics in the breastfeeding period though. So they can be used safely in the breastfeeding period with due caution. As far as rho kinase inhibitors and pilocarpine is concerned, they can be used with caution in second trimester and in breastfeeding, but adequate data is lacking in these two drugs and not too many publications are available to support the same. As far as prostaglandin analogs are concerned, this comes last in the list because contrary to the normal belief of starting prostaglandin analogs first, it being a uterine stimulant, it should be avoided in any stage of pregnancy. However, reports of uneventful usage are available and discussion with patient and obstetrician are prudent, but definitely you will not be using them in the third trimester near term or in the first trimester. They're likely to be safe in breastfeeding period due to the pharmacokinetics and faster elimination from the circulation. Lasers in pregnancy can be considered for mild to moderate but stable disease. SLT treatment is to be considered in open angle cases to reduce the drug exposure in the first trimester. Subset of beneficiary population is limited in most cases, as we all know that most of the diagnosis will be either congenital, juvenile or inflammatory glaucomas which have poor results with SLT and also have very high pressures. Small proportion of primary open angle glaucomas would benefit for the limited period of its effect. Peripheral iridotomy, iridoplasty would deliver similar effects in pregnancy as in non-pregnant women in angle closure disease. As far as surgery is concerned, if there is relentless progression of glaucoma in pregnancy, that is one option that you may have to consider in cases where the progression is quite rapid because of the limited safe armamentarium that is available. The challenges, however, would be with anesthesia. General anesthesia would be difficult. Positioning of the patient with a gravid uterus causing cable compression and syncopal attacks. Contraindication to mitomycin C because it is a X category drug. Limited data on mixed efficacy. GAD can be considered, not too many studies available. Limited antibiotic coverage post-operatively because macrolides are only deemed to be safe in pregnancy. And local anesthesia, definitely with lidocaine would be the safest. With small dose, maybe peribulbar or local infiltration at the site would be ideal. Bupivacaine has to be avoided because it can cause fetal bradycardia and should not be used in pregnant women undergoing surgery. So pointers are multidisciplinary approach with obstetrician, gynecologist and radiologist is mandatory. Risk-benefit ratio is the center point, irrational and avoidable medications to be withheld, progression to be closely monitored, informed choices and discussion with stakeholders, especially presenting with pregnancy on medications. It's mandatory to demonstrate eye closure and occlusion has to be stressed. SLT can be used in selected cases if diagnosed at appropriate times. So surgery without antimetabolites is relatively safer under lidocaine or local anesthesia, and it should be resorted in relentless progression and inadequate IOP control. And breastfeeding has its own rules and medication choice, so transition from pregnancy to breastfeeding should be well known. Thank you for your patient hearing.
Thanks, Dr. Sachin, for the nice information about pregnancy and glaucoma. So now I would like to call Dr. Ganesh V. Raman, Head of the Glaucoma Services, Arvind Eye Hospital, Coimbatore. Sir, for your talk about the role of SLT.
Thank you.
Ganesh, just a sec. Welcome Dr. J.S. Bhalla also. He is a member Scientific Committee AIOS and also heading the glaucoma service at DDU Hospital in Delhi. And he'll be inviting the next. Kiran is here. Please come forward. Go ahead, Ganesh.
Thank you. Thank you, Chairperson. I would like to thank AIOS for providing me this opportunity to speak to you on the current role of SLT. No financial interest in any of the products or devices discussed here. So the SLT now, if you go through the literature, you'll find that there are nice guidelines of UK and also the US have listed as the first line of treatment for primary open angle glaucoma. And the main advantage of that is that it removes the patient factor. Like our mentor, Dr. Alan Robin mentions, most patients miss some drops, some miss most drops, and few miss all the drops. So this is when I visited you in 2014. It's been 10 years since. And now we have the new devices which are coming to vogue. So this is a small study which we are conducting now, and I'll just share the results with you, brief interim results. So this is a 6-month recruitment and 1-year follow-up. Objective is to study the safety and efficacy of SLT. And if you see the mean baseline intraocular pressure was 24.76 before medication, and the mean visual field deviation was, MD deviation was 5.76. All the patients are faking, all 30 of them. And the end of 6 months, you have intraocular pressure of 18.6 millimeters of mercury. That's quite significant drop, almost 21% drop. Some of the patients are on medication. This is, of course, as I mentioned to you, interim analysis, so we'll be looking into the data further. But suffice to say that SLT works very well in open-angle glaucomas and ocular hypertension. This is the study group which we had included for this study. And this is something similar to what Dr. Srishti Raj and the group has published from the PGI Chandigarh. They did the SLT for angle closure. And I think now you also have the 5-year data of the same cohort. And you can have a look that the intraocular pressure reduction is almost 28% IOP reduction from baseline. So that's quite significant. So with no adverse effects, side effects. And similar to the juvenile glaucoma population, which was treated with SLT from the AIMS group, they also had a mean untreated baseline IOP of quite high, 36 millimeters. And pre-laser, the IOP was 25 millimeters of mercury. And after the laser treatment, the intraocular pressure fluctuated between the range between 10 to 22 millimeters of mercury. And with patients with normal open angle, they had a better response as compared to patients with angle dysgenesis. So previously, we used to have the flash pumped Nd:YAG laser. So it was a photo disruptor that could also function as a dual function laser. And you could use the double frequency version of it and do the SLT. The unfortunate thing with that was that the energy delivery was about 20%, plus minus 20% of the expected. Whereas now we have the diode pump neodymium orthovanadate laser. It works as a photocoagulator at the 577 nanometer green laser range. And this also has a dual function. And you use this, it has a 52 fast spot targeting the pigment epithelium in the trabecular meshwork. And the energy delivery of this is about plus minus 5% of the expected. So this consistently delivers the same amount of energy as compared to a flash pump. And you could always cross-subsidize these machines. You could use the photo disruptor for laser iridotomy or the YAG capsulotomy, whereas the photocoagulator, you can use it for iridoplasty or your pan-retinal photocoagulation or your even slit lamp-based transscleral cytophotocoagulation, or even for suture lysis. So what are the preferable prerequisites? You should have a good gonioscopy. This is not just for MIGS, even for SLT, you should be a good gonioscopist. And 50% of angle closure, 50% of eyes in our scenarios are actually angle closure. So it's very important that you pick up the correct patients for the procedure. Treatment-naive patients are the best. So we prefer to stop all medications before we do SLT. And after SLT, we consider stopping all the medication. We don't even give lubricants or NSAIDs. We prefer phakic eyes with early POAG or ocular hypertension. And we should also expect a delayed response to treatment for about 4 months. And you could have intermittent fluctuations in the initial 2 to 3 months. The main advantage of the procedure is that it can be repeated. So after about 3 months, if we don't see a response, if we see a suboptimal response, we can go ahead and repeat the procedure. So in conclusion, SLT should be considered as a first line of treatment in early primary open-angle glaucoma ocular hypertension, and can be considered in selective secondary open-angle glaucomas as mentioned in the literature. And the present technology allows for cross-subsidization, which can benefit glaucoma patients and their eyes. Thank you very much.
Thank you, sir. Now it's my pleasure and privilege to invite Dr. Kiran Gopalakrishnan, and he's going to tell us about practical pearls from landmark trials. Dr. Kiran, please.
Kiran, just a sec. There are enough time at the end for question answers. I would request the audience to please jot down your queries. You can either use the mics in the aisle or hand it over the pieces to Dr. Nayak, who will be chairing the question answer session also. Go ahead, Kiran.
Yeah, good afternoon, everybody. So I have the enviable task of covering 7 landmark glaucoma trials in the next 7 minutes and try to glean practical pearls from them. We will start with the ocular hypertension treatment study, which addressed the question, do we need to treat ocular hypertensives? Patients were randomized into the medication and the observation arm. The observation arm were put on medications at 7.5 years and followed up for a net period of 20 years. The headline results were that the risk of conversion to glaucoma could be reduced from 9.5 to 4.4 at 7 years, and at 20 years, the results were 49 to 42%. So from a practical perspective, it is pretty obvious that all the ocular hypertensives do not require treatment, because only an extra 8% gets protected from glaucoma if we treat. All ocular hypertensives are not alike. This is a well-known depiction from the OHTS trial that tells you that patients with low baseline CCT and high IOPs are at much higher risk of progression compared to ones with opposite parameters. And you can use the OHTS calculator for objective stratification. It's important to do both structural and functional testing in ocular hypertensives because more than 55% of patients with optic disc changes had no concurrent visual field changes. The EMGT looked at effectiveness of IOP lowering in reducing POAG progression. Patients randomized into observation and treatment, which was a fixed regimen of ALT plus betaxolol in keeping with the times. And the headline results were that the risk of progression could be reduced from 62% to 45%. From a practical perspective, treatment was beneficial across a wide spectrum of POAG. So it was effective irrespective of the IOP being lower or greater than 21, and was effective even when the field effects were slightly milder or slightly greater of more than 4.5 decibels. Now, all POAGs like ocular hypertensives were not alike. Some of them did progress faster, and the predictors of long-time progression included exfoliation, thin CCT, disc hemorrhages, presence of some vascular factors like low systolic perfusion pressure, low systolic blood pressure, and cardiovascular risk. The collaborative normal tension glaucoma trial looked at the effectiveness of IOP lowering in NTG, patients randomized into the observation and treatment arm, which aimed for an aggressive 30% reduction of IOP from baseline. And the results were that the risk of progression could be reduced from 35% to 12%. And the practical pearl from here is that most NTGs do not obviously need treatment, simply because 65% did not progress over 8 years despite no treatment. And keep in mind that the study only recruited severe or progressive NTGs. The mild to moderate NTGs that you see in the clinic will not have the same rates of progression as the study showed. The collaborative initial glaucoma treatment study looked at the choice of whether we should treat newly diagnosed POAG medically or surgically. The patients were randomized to receive either medication or surgery, which involved trabeculectomy with or without 5-fluorouracil. And the headline results were that both the medication and the surgical arm were equally effective in visual field preservation over a 9-year time frame. From a practical perspective, the standard approach of starting medical therapy and, if ineffective, shifting to surgery is actually effective, because not only were the visual fields preserved between the two groups, over 9 years, the quality of life was also similar in general between the two groups. But you should have a lower threshold for surgery in advanced glaucomas, as in the subset of advanced glaucomas, surgery fared far better than medications. The advanced glaucoma intervention study looked at advanced POAGs and looked at 2 treatment sequences, one starting with trabeculectomy and the other with ALT. And in the results, the patients were divided into 4 different groups, A to D, based on 2 parameters: average IOP in the first 18 months, which is a marker of early IOP reduction, and percentage of visits with IOP less than 18, a marker of consistency. Group A was the star, with less than 14 millimeters of mercury in the first 18 months and 100% of visits having IOP less than 18, and had practically no progression of visual fields over the 7 years of time frame. From a practical perspective, in advanced glaucoma, therefore, the risk of progression can be minimized by both early aggressive IOP reduction and sustained IOP reduction across all visits. But keep in mind that 18 millimeters of mercury is not a magic number, because in this group, the mean IOP was only 12.3, and despite this low IOP, 15% did worsen by 7 years. The tube versus trabeculectomy study looked at whether you should trap or tube eyes with prior ocular surgery. Patients randomized to receive either trap or a bowel tube. The results were that at 5 years, a higher failure rate was observed in trap, and also a higher rate of early post-op complications dominated by wound leaks and hyphema. But the rates of late postoperative and serious post-op complications were the same. From a practical perspective, you can probably expect even better results with tube with eyes with more prior complex surgeries, because the TVT only recruited prior cataract surgery eyes, which does not have an impact on the conjunctiva, and failed traps. Prior keratoplasties and prior vitrectomies might give better results with tubes. And valved implants like AGV may not offer the same success rates, because they generally tends to have higher IOP but have lower hypotony-related complications compared to the bowel tube used in the study. The primary tube versus trabeclectomy study addressed the same question, but in eyes with no prior ocular surgery. We again patients randomized to receive trab or the bowel tube. The results were that at 5 years, if you define failure as IOP greater than 21, trabs and tubes were similar. But if you redefined IOP at 17 millimeters instead of 21, trabs generally had better success rates than tubes, though it did not approach statistical significance. From a practical perspective, though the rate of IOP reduction between trabs and tubes were the same at 5 years, trab was able to offer the same results with fewer medications. Therefore, the rate of complete success was actually higher in the trab group. Therefore, this becomes a default choice, especially in patients with poor compliance and intolerance to medications. I thank you for your patient listening.
Thank you, Dr. Kiran, for giving at least brief, whatever the takeaway messages from various trials. Now I take liberty of inviting Professor Alan Robin, who has got 2 topics to cover. He is a very well-known figure in India. Probably he is more seen in India than his own country. And he is Professor of Ophthalmology, University of Michigan, and Associate Professor and of Ophthalmology and International Health, Johns Hopkins University. So he has got 2 medical therapy, principle and adherence, and pseudo-exfoliation syndrome. Thank you.
Thank you very much, and it's an honor to be here.
And his timings are 10 minutes each. No, there, yeah, okay.
10 minutes, sir.
Yes.
Thank you very much. It's an honor to be here, and I appreciate the opportunity. I'm going to talk to you about some work that we've done in both of my talks, both first about medical therapy and then about pseudoexfoliation. You know, when you see patients and you look at them, and this is a real patient and both eyes are about the same, who progress over a 7-year period, despite the fact that the IOP has always been controlled, you wonder why. Or if you look at the study, the early manifest glaucoma treatment study that showed the medicines do work better than no medicines, or treatment better than no treatment, but that half the patients still progressed who were treated, don't you wonder why? And I think the reason is we're blinded to the fact that we just don't talk to patients and miss the fact that patients don't take their medicines or can't get them in their eyes. And what I'm going to do today is talk about that. And I'm going to say that most of the blame is with us, not the patient. One of the reasons that patients look like they do well is because they want to please you. Patients don't want to come in and have you scold them. They want to make you happy with them. So this is an asthma study where they had an inhaler, and there's a microprocessor chip in the inhaler, and every time the inhaler was pumped, it registered. So the inhaler was dispensed. As you could see, patients did well for a while, then they forgot it for a while, so they took some extra inhalers. And then right before they came to see the doctor for a couple of weeks, they didn't take anything. But before they saw you, they took a lot of inhalers, so their asthma was doing well. Likewise with glaucoma. This is a slide on systemic hypertension from a great researcher called Virgins who work with Ocular. And the green line is perfect adherence. The y-axis is your percent of patients who did well, and the x-axis is time. And this is a year study. There aren't that many one-year studies in adherence. And you can see there's an initial drop-off right here where people just don't even believe in it. You know, this isn't going to make me well. It won't do anything. Why should I even take it? Or it's too expensive or whatever. Then patients gradually taper off. The dotted line is different, and that has to do with execution. And that doesn't mean hanging something or whatever, but it means something we'll talk about in a second. So the first lesson, we have 5 lessons today, is ask patients if they're taking their medicines, because that means you care about them, and that'll really make a big difference. But there's a corollary, and that's don't believe what they say if they say they did take them. Adherence in ophthalmology is much different than it is in regular medicine. And why is that? Well, first of all, you have to get the drop in your eye. You know, unless you're dysphagic, you can get a pill in your mouth. And the other thing is various bottles are different. Now that we have so many generics in the United States, and you have tons of generics in India, all the bottles are different. And so there's different squeezability. You get more drops out. It's harder to get the drops out the bottle. There's been a couple studies showing that there's a real difference in different eye drop bottles as to how many drops you squeeze out and how hard it is to do. So if you have a patient who has a problem with their hands or paralysis or Parkinson's, ask them about that. There are two good ideas in eye drop bottles that came up. One was the CCAP from Betagan. This is levobutanol maybe 20 years ago. And sometimes if people take medicines, and I'm not on any, but did I remember to take it today or not, or should I take it? And there was either, if you took it once a day, there was a Saturday, Sunday, Monday, Tuesday on the cap. You just twisted the cap. Or if you took it twice a day, there was a 1 or 2, which is really sort of a neat idea. But because it didn't sell more Betagan, they never pursued it. Travatan had a dosing aid, and you can see this here, which actually helped you squeeze the bottle, and had a microprocessor chip in it that helped you remember to take the bottle and helped you and the doctor know what's going on. Didn't sell more Travatan, it didn't work. So lesson 2 is ask patients if they're having trouble with their bottles. If they're having trouble squeezing too much, too little, can't squeeze it. Important, it's physical, but it's very important. I'm going to talk about execution now. There's nobody with a noose around here, but it's the ability to instill a drop correctly. You can see here, this is a lady 4 days after trabeculectomy. I'm going to replay that for you again. I hope, right there. Well, maybe I won't. There it is. So I think she's wasting a little drop, so if you ever have a wound leak after a trabeculectomy, that may be why. And here's another lady. Hopefully it's going to work. There. There. Okay. These are all patients who say they've been on glaucoma medicines for over a year and have no problems taking their drops. So if you wonder why this patient has her pressure going up, it's because she doesn't even get the drop in her eye. She got it in her nose. This is a optometrist mother who's sort of wasting her drop and putting it in sort of weirdly. And this is the patient who says he has no problems getting his drop in his eye, and this is a modified version of punctal occlusion, in my opinion. So from some of the studies we've done, we found that patients don't do that well. If you look at people who can only get 1 drop in their eye and don't contaminate the bottle, you're talking about probably 20 to 30%. And different bottles from our study, although we didn't intend to look at that, did have different results. So lesson 3 is patients are clueless. They don't know if they're doing well. So remember to do that. Look at that. And the corollary is, if they can't get a drop in their eye, why are you giving them eye drops? So make sure that you look at patients when you prescribe eye drops. Take a bottle of artificial tears or something, ask them to put it in their eye. If they can't get in their eye, do SLT, do a surgical procedure, do something, but don't give them eye drops. Adherence or compliance, and this is really adherence, this was a misquote by Mike Cass. This is 40 years ago, and what Mike did was put a monitoring device, a microprocessor chip, inside of both a pilocarpine and a timolol bottle. And to measure adherence, what he did was, if you took the top off and turned it upside down, it would record that you used it. And we all thought, and you all use pilocarpine more than we do in the United States, that the afternoon dose or the evening dose was the hardest to remember. The answer is, that's not the case. It's really the nighttime dose is the hardest to remember. The morning dose is easiest. So for those of you who give patients prostaglandin and tell them they should use it at nighttime, you may want to reconsider. You may not be quite as effective, although it's not that much of a difference. But you may want to consider having them use in the morning. At least they get it in their eye. We also think of adherence as just a problem of too much or too little. It's also a problem of too much. Mike Cass's other studies with timolol, and 1/8 of the patients were took their timolol more than 3 times a day for at least a week in a 1-month study, which is pretty impressive. There was an article that just came out, I saw about this, a gentleman talking about too much, who had 217 COVID shots in the last 4 years. And why he did, I don't know, but that's really an example of a little too much. We also did a study with microprocessor chips looking at the difference between 1 and 2 drops. That is, if you use 1 medication or have 2 and 1 adjunct medication. And in the 1 drop group, most people did really well. And in the first drug for this, for the people on 2 drugs, people did pretty well. But as soon as you add the 3rd line, as soon as you add a 2nd drop, people do horribly. So the bottom line is, as we said before, simplify the medical regimens. Don't just add medicines. Try a different class of medicines, use a combination medicine, but just don't keep on adding medicines. I'm going to finish this with the doctor-patient relationship. We all think we do great. We love our patients. We talk to our patients. No, we don't. This is a study we did that was published a few years ago where we had 15 different glaucoma specialists, well-known people, seeing 279 patients. All either were newly diagnosed or had their medical therapy changed. And as you can see, we had a camera in the room. We video recorded the whole interaction. Doctors and patients both signed informed consents, and the doctors thought it was all about the patients, but they all performed best. So this is the best case scenario. You can see that at both at the initial visit, the 1 month and 3 month visit, the doctors did not talk at all about how many drops they were supposed to take, how long they're going to use it, why they were taking it, and even which eye to put it in. This is pretty horrible data. I mean, we do a horrible job. We had a focus group recently looking at what patients really want to know. And these are common things, but we don't tell them these things. We're really bad at this. You know, what's glaucoma? What is an ideal IOP? Why do I have to take these dumb visual fields like Dr. Asrani was talking about this morning? And why am I taking these medicines? What are their side effects? We don't mention any of these things. We don't even have our assistants do it. So my suggestion is, you can see the slide, take a picture of it, and give the patient a note card. Have a little thing in your waiting room, and say, have them ask 3 questions. And that way you're ensuring that they do something, you're interacting with the patient, and you accomplish a lot and show that you care. Thank you. Can I go to my next talk?
Yeah. Can you project the second talk of his, Professor Alan Robin?
Next set of slides.
Yeah, the second talk is based on a question that came on the glaucoma net in the United States about, 17 years ago, when a famous glaucoma specialist from Canada said that, everybody with pseudoexfoliation should have a CTR placed in their eye and all that kind of stuff. And one of the famous glaucoma specialists in Baltimore said that everybody with pseudoexfoliation has hyperhomocystinemia and should be treated. And I said, there's no data. I started looking at this. So with the grace of all the wonderful people at Arvind, we were able to do a spectacular study with almost no cost. The intraocular lenses were donated by Alcon. They had nothing to do with the study, didn't analyze the study. I don't even know if they know it's done. And the CTRs were supplied free to the patients by Oralab, which is Arvind. We all know, this is from our prevalence study that we did 20 years ago, that pseudoexfoliation is very prevalent in India. And we also know that both pseudoexfoliation and cataracts increase with age. So we decided to do a study to see what the best way to treat these people who have cataracts who have pseudoexfoliation. So this was a 6-arm prospective study with almost 1,500 patients that we were able to complete amazingly in a little bit over a year. All had to be over the age of 40 years and requiring cataract surgery. They all had visually significant cataracts. And our control group were people who had cataracts but did not have any other comorbid eye diseases. So visually significant cataracts, willing to do phaco, and endothelial count that's important of over 1,500. And we excluded, and this is important also, patients who had pre-existing phacodenesis or pupils smaller than 3 millimeters. We followed everybody up for a day, a month, 3 months, a year, and yearly for 10 years. And during COVID, we missed year 9. That was one of the things that happened. So these are the 4 groups. In the pseudoexfoliation group, either a 1-piece or 3-piece IOL, with or without caps or tension rings. And we have about 235 patients in each group. In the control group, who just had cataract, it was either a 1-piece or 3-piece IOL, about 240 patients in each group. No CTRs were done. We looked at systemic issues. We had a history. We did blood drawn for glucose, cholesterol, homocysteine. We measured blood pressure, did a 12-lead EKG, and we did blood sugar counts. We also did a total ophthalmic workup for visual fields, gonioscopy, specular microscopy, the whole deal. And we defined things before the study began of an IOL decentration of greater than 1 millimeter, And a capsulotomy, you have to have at least one line of vision lost. And we define glaucoma based on visual field and based on disc, but not based on intraocular pressure at all. So as you would expect, there were differences in the group. Interesting, the pseudoexfoliation group was a little older and had more males, as you would expect. Regarding systemic associations, it goes all over the board. There's all kinds of reports of the Blue Mountain study of people dying prematurely. There's evidence that homocysteine is a big problem. So we wanted to find out what the story is. So significant things were systemic blood pressure was higher in people with pseudoexfoliation. There's no significant difference in homocysteine levels, absolutely none whatsoever. We found that LVH was very significant, and all cardiac morbidity was important. We'll talk about that later on, but those were the important things we found different in all the testing we did for pseudoexfoliation. So there was a strong association with systolic hypertension and mean arterial pressure and LVH, no association with diabetes, cholesterol, or hypohomocysteine. What about intra and postoperative complications? Well, preoperatively, the intraocular pressure, as you might imagine, even though there were only a few people with glaucoma in the pseudoexfoliation group, was slightly higher. After that, for the first year, there was no significant difference. If you look at the intraoperative complications, that is during surgery, there was no significant difference. Now, granted, these are all surgeons who are really impressive. They can do up to 100 cataracts in a morning and are very experienced and have great hands. And my wife was operated on by one of them. But this is not the average run-of-the-mill cataract surgeon, but that's important to realize. On day one, we saw more corneal edema in the pseudoexfoliation group, but after that, there was no different on day 30 or day 1, and there was no other significant difference in iritis or IOL centration, phimosis, no difference. What about glaucoma? This is at 5 years, so I'll talk about 10 years. We haven't analyzed that yet. There was a 7-fold almost, or 5-fold increase in the numbers of the people who develop glaucoma by field and disc at 5 years. So that's important for you to realize. That's lesson number 6, to make sure you look at people with pseudoexfoliation and assess them for glaucoma more often than you might have, depending on their age. What about at 10 years? This is brand new stuff, just off the press, so to speak. Not published, but off the press. We did pretty well in recruiting, except for death. We were able to follow 82% of patients for 10 years, which is pretty impressive. We had a high rate of mortality. Now, whether or not this is more than age-adjusted norms, I don't know. And whether or not this was more in the pseudoexfoliation group than the non-pseudoexfoliation group, I don't know yet either. But these are the rough numbers. Means are deceiving. What about IOL decentration? Do you need a CTR? No, you don't need a CTR. There's no difference. What about capsulotomy? Do you need to do, there's an increased risk of capsulotomy in people with pseudoexfoliation? Nope, no difference whatsoever. And no difference in 1-piece and 3-piece IOL, and no difference between CTR and no CTR. There it is. What are the risk factors for IOL decentration? Although it didn't happen very often, what are the risk factors? Well, one of them is denser cataract. The second one was capsular phimosis, probably weaker zonules. And one was a rhexis that overlapped the IOL. So these are things that are happening that you should be aware of. What about that risk with Cox proportional hazard analysis of need for capsulotomy? And again, it's a 3-piece IOL and older people and people with a bad rhexis. So those are things important. What about vision? It's interesting that the vision in the pseudoexfoliation group at almost all time periods was significantly worse than the non-pseudoexfoliation group. We're looking at the data now to figure out if it's macular degeneration, if it's because they develop glaucoma, whatever the reason is, corneal decompensation. I can't answer that at this point, and I hope I can at some point. It's similar to the rates in other studies showing that there is a significant risk of cataract surgery in those groups too. Okay, conclusion. This is the first large-scale prospective comparative study with long-term follow-up results looking at pseudoexfoliation eyes undergoing phacoemulsification. emulsification. These were all phaco, no small incision cataract surgery. in eyes who have at least a 3 millimeter pupil without phacokinesis and do not have a higher risk of IOL decentration or PCO. A CTR is not required in these eyes with or without intraoperative phacokinesis. And IOL choice, 1 or 3 points, it doesn't really matter. You can have a one piece or 3 piece, it doesn't really matter. Thank you very much. I appreciate the opportunity to be here.
Thank you so much for such lovely talks. Now I'll request Dr. Sanjay Srani, who's come from Duke's University, USA, to present his talk, how to manage normal pressure glaucomas. Truly, they're almost 1/3 in India as well, so I think it will be great to listen to you.
Yes, thank you for your kind introduction, and thank you for the audience for staying awake despite a very nice lunch. Normal tension glaucoma is the biggest challenge we face in glaucoma management. First, to identify it, and second, how do you manage it? Okay, so normal tension glaucoma is the imbalance of 3 or more factors. If there is intraocular pressure fluctuations of more than 3 millimeters of mercury in the normal range, low diastolic blood pressure, low cerebrospinal fluid pressure, but of course, provided a correct diagnosis is made. The diagnosis is one of exclusion. You have to rule out masqueraders. Masqueraders include any problems or abnormalities in fields or nerves in the presence of a normal pressure. And early stages of both primary open-angle glaucoma and narrow-angle glaucoma will masquerade as normal pressure glaucoma because the pressure spikes are less frequent in the early stages. What are the masqueraders of normal pressure glaucoma? Old burnt-out glaucoma, primary open-angle glaucoma with a false reading, such as fluid in the cornea due to LASIK or corneal edema, current glaucomas, intermittent angle closure, early stages, active uveitis, because they don't produce aqueous humor, and chronic angle closure. The unusual suspects, these are vitamin B12 deficiency, neurosyphilis, optic atrophy, anomalous disc drusen, retinal diseases, or any brain mass or scar all along the optical pathway all the way till the lateral geniculate body. So what are the questions that help me identify that this patient is more likely to have normal pressure glaucoma? Migraines. Do you have migraines? No. Did you have migraines? Yes, I did. So it depends on the question you ask. So you have to ask question correctly, because if you say, do you have migraines? They will say no. Usual blood pressure. If they say we don't know, but the medical doctor said they are very pleased with our blood pressure, that means it is low. Raynaud's phenomena. You're not going to experience Raynaud's phenomena unless you go to a cold place. So the one thing I ask is the spouse. When you touch the hand or the feet, is it very cold? Is it ice cold? That tells you that this may be cold extremities. And then the next set of questions are somewhat unusual. Do you take over-the-counter supplements like vitamins, bilberry, goji berry, and things like that? What is the waist circumference? Is it below 33 inches or more than 33 inches? Do you have other medical conditions? They will typically say no. No other medical conditions. The waist circumference will typically be below 33 inches, and they will be taking multiple vitamins, over-the-counter supplements, things like that. They don't experience thirst. They are unusual, and they exercise to an extreme. I don't know why, but they want to feel better. So you'll see this 80-year-old lady coming in sneakers to your clinic because she walks 6 miles a day. That is unusual for an 80-year-old to be walking 6 miles a day. And how many days do you do that? Oh, all except one day of the week. I do it every day. That is unusual. And this is based on a study that we had done in 2011, where we found that the weight, the waist circumference, the BMI, all differed. The number of prescription drugs was 1/3 the number of supplements. And another thing was the higher education level. More higher education level means more normal tension glaucoma. We were a little hesitant to publish this. Of course, we got a lot of pushback from the reviewers, but I was pleasantly surprised to hear from Joost Jonas and Vinay Nangia that in the central Indian study also they found that those people who had low CSF pressure had much higher education. So yes, there are certain systemic features that can identify low pressure glaucoma, but can you look at the patient's optic nerve or visual field and identify low pressure glaucoma? Yes, there is in low pressure glaucoma a focal notch. The rest of the nerve is completely well preserved and pink. Of course, this is in early to moderate stage. The paracentral loss of visual field, the parafoveal ganglion cell loss, and of course, nasal and temporal loss is typically neurological, as I mentioned in the morning. This is a classic example of a disc which has a focal notch like here, and you see that the rest of the rim is completely intact. You see this focal notch right here, and the rest of the rim is completely intact. This is classic of low pressure glaucoma. So, is this low pressure glaucoma? No. There is a little temporal pallor. You can see one other feature, and that is you see these curvilinear changes in these blood vessels. This tells you that this patient has Leber's hereditary optic neuropathy. So when you see this kind of feature and the patient's vision is normal, you have to be cautioning them to avoid smoke exposure and to take adequate vitamins so as to reduce the impact of LHON. Let's take a look at this example. This patient has a pressure of right eye in the mid-teens, left eye in the single digits to low teens. This is the gonioscopy. Is it normal tension? Is it neovascular, or is it normal? Pressure in the low teens in the left eye. This is gonioscopy of the left eye. It's not normal tension glaucoma because the pressure is not fluctuating much. Is it neovascular glaucoma? Could be. It is, possibly. Yes, it is ocular ischemic syndrome. It's because the low perfusion of the ciliary body. That's why there is low pressure, even though the outflow is obstructed. But why am I showing you this picture? Why am I showing you a picture of the patient's eyes? Because you could have made this diagnosis as soon as you entered the room. You did not need to even look at the gonioscopy. You see the arcus here? There is no arcus on this side. Whenever you see a unilateral arcus, it is because of carotid occlusion. And you have to remind those patients after they get the carotid endarterectomy to come back so that because they will get florid hyperperfusion glaucoma. So, establishing a diagnosis, you look at this nerve and you might say, maybe glaucoma suspect, maybe not. But then when you look at this, you'll say, aha, definitely glaucoma. You can see so many nerve fiber layer defects. But is it? Is it glaucoma? With so many nerve fiber layer defects, where is the cupping? There is no cupping. Because nerve fiber layer is known to be affected in hypertension, especially if the defects are multiple, especially in the macula. It is associated with systemic vascular risk factors rather than glaucoma. These may be useful in grading arterial hypertension. The odds ratio of getting a nerve fiber layer defect in grades 2 and 3 of hypertension is 10 times. the risk. Severe hypertension causes thickness decrease of macula and RNFL over time, reminding you that these are the two layers that our artificial intelligence is focusing on to predict over time. Unfortunately, there is this other player, which is hypertension and other diseases. For example, this is a slide I showed yesterday. There is a loss of nerve fiber layer that you can see here over time. You see a loss of macular thickness. You see a focal field defect. So if it looks like a duck, walks like a duck, talks like a duck, must be a duck. No, it's not a duck. It's not glaucoma. Because 3 months prior to that, there was a cotton wool spot that had been noted. That was the cause of all these changes that look like glaucoma. So how do you identify glaucoma? Nerve fiber layer loss, cupping, that is the Brooks membrane opening minimum rim width, progression over time at the same location, and ganglion cell and inner plexiform layer loss, but no loss of the inner nuclear layer. In cotton wool spots, no progression, no change in cupping, ganglion cell loss, and inner nuclear layer loss depending on the location of the cotton wool spot. So you can see here there is a nerve fiber layer loss, but in the location of the cotton wool spot, you'll see that there is a fold in the middle of the retina. So if you see, you can see these folds in hypertensive patients. I used to never know what these meant until recently. You can see this because of the multiple cotton wool spots. So let's go back. Fluctuations is critical to control in management of low pressure glaucoma. So what do you do? Okay, you identified low pressure glaucoma, you eliminated masquerades, but you see, we did a study in which we did SLT and we found that the mean pressure did not change much, but the range of pressure changed significantly. That means the fluctuations went down. And then there is low diastolic perfusion pressure. If you have less than 55, that is diastolic blood pressure minus intraocular pressure, it is a major risk factor for all these studies. Look at the number of patients that causes progression of glaucoma. CSF pressure, definitely. CSF pressure is completely dependent on BMI. If the body mass index is low, CSF pressure is low. So what do you do? Last conclusion, 2 slides. Tell them, avoid dehydration. Drink water throughout the day. You don't want them to be drinking 2 glasses in the morning and 3 glasses in the evening. That's like doing a water drinking test. You want them to keep drinking, sipping water through the day. Avoid weight loss. Any weight loss worsens hypotension and therefore causes low perfusion. Adequate salt, because typically the spouse has hypertension and so there is no salt being added to the diet. Reduce exercise intensity. Do they really need the hypertensives? If so, take it in the morning. Reduce fluctuation and make sure that the pressure is below 15, because if the diastolic is 70, 70 minus 15 already reaches 55. Flammer syndrome features help identify diagnosis. Patients who can maintain a stable IOP after TRAB or SLT have stability of disease. Patients will get significantly worse if they lose body weight. Any loss of tissue preceded by a disc hemorrhage, especially in the superotemporal part of the disc, is more critical for vision because it means that the patient will develop an inferoparacentral loss of vision, which is critical for reading. And we still don't understand the interplay between all these factors. Thank you very much.
Yeah. So now we have the, thank you sir for very nice illustration of this wonderful talk on normotensive glaucoma. Now we have the last talk of the session by Dr. Steven Mansberger, and he's going to talk on how do you know that you are losing the battle. Dr. Steven, please.
Thank you. Thank you for the organizers for having me be here. These are my disclosures. They don't have much to do with what I'm going to be talking about today. So, you know, this is probably well known to the audience, but, we talk a lot about diagnosing glaucoma and making sure that it's the right diagnosis, but really, once you have the diagnosis, the key thing is determining the rate of progressive glaucoma. This is going to help predict, as Alan Robbins said, what the risk of going blind is over time. I'm also going to talk about structural progression and how you detect that, and then maybe some new ways of detecting progression. So here's this case. You have a 65-year-old female who's in your clinic. Her pressure is 18. Her central corneal thickness is 530 microns, and the question you have to yourself is, gosh, is her glaucoma progressive? And if so, how fast? And what you do notice on this exam is you see this disc hemorrhage here. And this disc hemorrhage, is going to be associated with progressive glaucoma. So this is kind of what we're going to talk about today. How do you approach this lady? So what does visual field progression look like? It could be a deepening of an existing scotoma, so the sensitivity in that one scotoma gets worse. It could be a widening where the visual field defect becomes a little bit larger, or it can be a completely new area of damage. And there's two ways of looking at, you look at event-based testing, looking at whether or not this looks worse, according to a certain baseline. And there's these rate-based changes. So you have two kind of slides here where you can look and see down here, when you're plotting mean deviation over time, the mean deviation is pretty darn stable. Where on this patient here, you can see the mean deviation is going worse relatively quickly. This is the person you really need to worry about. This is the one you need to be aggressive about the treatment. This is the one you need to talk about adherence, like Dr. Robin had talked about. And this is the one you may have to just operate on. So it's really, really important to determine progression and determine the rate of progression. So there's a really nice paper by David Crabb in IOVS in 2014, where he took all of the visual fields from the National Health Service. They had 400,000 visual fields, and over about a 15-year period. And what I want to look at on these visual fields is how often they went blind or they lost vision. And then he determined, virtual visual impairment with mean deviation worse than -14, and blindness as defined as a visual field defects or visual field sensitivity less than -22 decibels. And what he was looking at is, like, for example, this patient here at baseline, how often they had a little bit of vision loss but never reached this visual impairment, or somebody like this who became blind over time. And so this is just kind of a point cloud of each of the patients, and each color means a certain thing. So the green means that they never developed visual field loss over their lifetime and they became blind, where the yellow mean they became visually impaired, and the red shows that they became blind. And what you can see here is that actually, and there's one other color, there's blue. I'm not sure if you can see that. The blue actually says they've been improved. And so what you can see is about 7.5% had a rate worse than 1 decibel per year. And 1 decibel per year, you'll remember, is going to be the rate in which somebody is likely to become visually impaired over their lifetime. 3% were considered fast progressors at more than 1.5 decibels per year, but 33% had positive visual fields. They actually got better over time, maybe just because they got better at the visual field. 90% of them, 90% of blindness were worse at baseline, so those patients that came in that already had progressive glaucoma or severe glaucoma, and about 5 to 7 became blind over their lifetime. So what rate of loss is significant? So just like I showed you here, the David Crabb study was about 1 decibel per year. The EMGT also had about a very similar 1 decibel per year. Rossetti, again, had 1 decibel per year. So all these studies are kind of showing the same number, and if you want to compare that to the visual field index, it's about 2.5% per year. So those are the patients that you're going to get really aggressive when they have faster loss. Now, if it's a 50-year-old who's got maybe a 1% per year, you might be more aggressive than an 80-year-old who's having 2.5% per year. The other thing about these studies show us that we need to retest abnormal visual fields, and this comes from the OATS study, where at least 66% of visual fields that were abnormal became normal on repeat testing. So just repeating the visual field before you advance therapy, I think, is a key feature as well. So here's some examples. This is a visual field where it looks like they had some loss on top and bottom below. You might say, oh gosh, this is an artifact from the lens being too far away from the eye. And then they repeat it, and the visual field defect goes away. Here's another example. Looks like pretty classic glaucoma where they get a visual field defect right there at fixation. They repeat the visual field, and lo and behold, it goes away. And here's another example where it looks like there might be a nasal step here, pretty obvious. Again, they repeat the visual field, and it went away. So again, you know, I don't advance therapy unless I can confirm that the visual field is indeed getting worse. And then finally, when to check 10-2 visual fields. That's become kind of a hot topic because our 24-2 visual fields don't have a lot of presentations in the center. The 10-2 visual fields has 68 points in the central degrees, where there's only about 4 with a 30-2 or 24-2. And a fair number of patients who have normal central testing with 24-2 have abnormalities with the 10-2. The second thing we heard already today was about the importance of looking at the optic nerve. And if you're not looking at the optic nerve, you're going to miss at least 50% of those patients who are getting worse. This is a paper that we published a while back looking at what happens to the optic nerve, because we keep telling people they need to look at the optic nerve, but we don't tell them what to look for. And if you look here on the left, you have a normal optic disc, and this focal notching is actually really uncommon. And it's only about 16% of the way the optic nerve changes, where you'll get regional or diffuse rim thinning. That's the most common at 54%. And excavation, where the rim just seems to be undermined, that is the most common form of progressive glaucoma by the optic nerve, at least on disc photos. And finally, nerve fiber layer defects occur uncommonly. So those classic pictures of a notch or a nerve fiber layer defect, those are actually uncommon in glaucoma. It's really this generalized thinning. So these are some examples. Here's a photo of somebody who got worse, and what you can see here is this vessel here lost its supporting structure. You can also see this enlargement of parapapillary atrophy. There's also some more thinning up here. So this is an example maybe of focal thinning. This is a person who you can see has a disc hemorrhage. If you see a disc hemorrhage, take a photo because that's where the action is going to be. And you can see this enlargement of a nerve fiber layer defect, also a nerve fiber layer defect up here. And then finally, this is not a subtle. This is a patient who had photos way back when. It was on volume 2, volume 3, and I ended up pulling out volume 1 one time, and I'm like, oh my God, their optic nerve really has changed over a long time period. But this is generalized cupping, and you see all these changes in the vessels, this parapapillary atrophy, et cetera. So we talked a little bit about disc hemorrhage already. Examine for non-glaucomatous causes. Ask about non-adherence, because if you see a disc hemorrhage, it could mean that they weren't using their drops and they're just trying to make you happy and using the drops just before their visit with you. And advanced therapy if the benefits outweigh the risks. And I always take a photo because that's where the location of damage is going to be in the future. Finally, I'm just going to talk quickly about algorithms for OCT. We've got 3 different ways of checking the OCT for progression. We've got our sectoral scan, we've got our circle scan, and we've got our macular scan. The circle scan is the highest sensitivity to determine progression. It's common to all devices, is easy to plot, and there's some differences in measurement techniques. And so this is my most common one. But the macular and ganglion scan can be really great when the patients have a lot of parapapillary atrophy. There's some data suggests it's better for detecting myopic glaucoma from just myopia. And finally, the sectoral scan with the minimum rim width, that's something that we have done quite a bit at Legacy Devers in Portland, and we think it might be better for patients with more severe glaucoma. There's less of a floor effect. So some take-home points is visual field loss of 2.5% per year or 1 decibel a year is a risk for progressive glaucoma or for visual field disability. Photos or on-face imaging can be really useful to document a disc heme and changes near the vessels. Disc heme is a location for future damage, and use the right OCT for the right patient. Thank you.
Yeah, thank you, Professor Steve, for really giving a clear picture that how to assess the rapid progression and on perimetry and the disc evaluation and OCT. So I'm sure it will help in the practice. Now, since we have time, audience, do you have any question with any one of the speakers? So then you can come up to the mic, and then you can, yeah, Dr. Ram.
One question to Dr. Asrani. How much importance should we give to the arterial attenuation which you may find in normal tension glaucoma if you look at the fundus photograph? Do you feel that that's important? Because once we want to, it's a disease of exclusion, we do understand, but once you want to rule in, there's a nice article by Dr. Douglas Anderson, 2011, I think, when Dr. Bayurnayak sir was the editor of IJO. He published a review article. So he mentioned that look at the arteriolar attenuation of the arteries, and then if that's one important aspect of normal tension. Would you agree to that?
No, unfortunately, I don't agree with that, because I think that wherever there is a loss of tissue, there is going to be arteriolar constriction, because that tissue doesn't require that much blood supply. So I think that's just a feature of the focal extent of the loss.
Another question is, how much would you attribute sleep apnea component for normal tension glaucoma? Because we do work up those patients with sleep apnea tests. We do the titration, we do the sleep apnea, and then we do the titration as well.
Yes. So sleep apnea can occur in both kinds of glaucoma, both normal and high pressure glaucoma, in which the condition is so unique is that their arterial hypotension occurs early in the morning, and their intraocular pressure spikes also occur early in the morning. So it is that perfect storm that causes progression. And so I find that patients who have a history of atrial fibrillation, even though they are slim, trim, and fit, they are the ones I send for sleep study, because they typically will have sleep apnea that is causing the atrial fibrillation. You treat the sleep apnea and the atrial fibrillation goes away.
So Dr. Sanjay, one more question to you, because you very nicely you presented all the, how to exclude that, because it's a diagnosis of occlusion, normal tension glaucoma. Once you have established the diagnosis, what is your first preference of choice or treatment?
So my first, once you have say, okay, this is low pressure glaucoma, the patient fits the bill, they typically have to have at least 2 of those features. They don't have to have all, like migraine, Raynaud's, and things like that. My first approach to them is education, to change their lifestyle. Hydration, not to lose weight, not to over-exercise. And second is I try to bring the pressure down below 15, because typically the diastolic is below 70. Third, I try to control IOP fluctuations. So I will go typically to either a prostaglandin or SLT. SLT is my first choice, typically, because you get the best effect when the patient is treatment naive. And my goal after SLT is not just to lower the pressure, but to reduce that fluctuation that happens from visit to visit, which is one of the hallmarks of low pressure glaucoma. Their pressure is usually 7 at one visit, 18 at another visit, 11 like that. They just keep fluctuating.
So one question, sir, like you said, one of the targets should be to keep the intraocular pressure less than 15. As an add-on drug, would you prefer carbonic anhydrase inhibitors over alpha agonists, because they tend to increase the ocular perfusion pressure much more than any other class of anti-glaucoma medications?
You read my mind, absolutely. That's a perfect question, because there is this controversy that Dr. Tanuj Dada and I were discussing about the LOGIT study that had shown that brimonidine was actually more effective in preserving visual fields over timolol in low pressure glaucoma. But what I have found is that brimonidine, which is actually a cousin of clonidine, is a very potent anti-hypertensive agent. So it causes severe hypotension. and therefore I don't like using it in low pressure glaucoma. And those patients I use carbonic anhydrase inhibitors as my second line of treatment.
Thank you, sir.
Any other queries from the audience? There's another mic next to the cameraman, so you can go up there and ask. All the speakers are present here in the front. You please ask. Dr. Bhalla has another query.
Yeah.
Dr. Bhalla, you have another query?
To Dr. Sachin. So for, like you said, we should not use this carbonic anhydrase inhibitors, and prostaglandin should be avoided in all stages of pregnancy, but you can give during lactation. So if you can just summarize for the sake of audience, in first trimester, second trimester, third trimester, and postpartum period, which will be the class of drugs? Like what I understood is first and second trimester, alpha agonist like brimonidine, and
Yeah, all
third
trimesters it's
carbonic
brimonidine
anhydrase.
except near the end of term.
Yeah,
And
near the end of term.
peripartum, because it causes respiratory depression in infants, but it is the only class B drug. All others are class C. As far as dorzolamide and carbonic anhydrase is concerned, in breastfeeding they are deemed safe by American Association of Pediatrics, so they are safe. Prostaglandins, there are reports of safe usage in pregnancy, at least in the last 2 trimesters, but theoretically it looks a risky proposition because they are causing uterine contractions by their own physiological action. So that's the summary of it, and beta blockers that are recommended are in 0.25% concentration. But the catch here is that most of the people who present in pregnancy, considering the physiological age, I'm not talking about older mothers, those will have the diagnosis which will be more in terms of developmental and juvenile glaucomas, which may present in a moderate or advanced stage. So that is the kind of population where actually you have to catch them before actually they get into a pregnancy, and counsel them or maybe manage them aggressively because before the pregnancy starts, because it's something you are shooting in darkness, because you don't have a firm answer due to lack of trials. So that population catching before actually they hit the pregnancy is important, and if at all you catch them when they are pregnant, and maybe especially nearing the first trimester end, and you should involve the radiologist and the counselor also.
Sachin, stay because there's another query.
Just query is, as you told, carbonic anhydrase inhibitor is safe in nursing.
Yeah. That's the recommendation of the
American
AAP.
Academy of Pediatrics.
Yeah.
So another drug is also, they have told beta blocker also safe.
Yeah, but they say 0.25. That's what they mentioned.
By American
But they say use with caution, keeping a watch on the heart rate.
Okay.
Yeah.
And you already told.
What about ROC inhibitors?
ROC inhibitors, they say that the data is lacking, but in lieu of data, you can use them with caution. That's what they normally recommend.
Sir, ROC inhibitor, they have not classified in any category.
Not classified.
E classification, E or extra, yeah. So it is not risk of expression.
A question from Dr. Alan Robin. So what happens to progression of glaucoma after cataract surgery in pseudoexfoliation patients? Does it help in stabilization of glaucoma also?
You had a second question, I missed that, I apologize.
So the question is, what happens to glaucoma progression in a patient of pseudoexfoliation when phacoemulsification has been done? Like a group phacoemulsification not done, and another group phacoemulsification done. Does it affect in any way progression also?
Are you, I'm not sure, let me ask to make sure. Are you saying that in comparing phacoemulsification to 6 or phacoemulsification?
No, phacoemulsification to no surgery.
Her query is what happens to glaucoma post-cataract surgery?
Post-cataract surgery.
Does it progress same way or is progresses lesser?
I don't know. My assumption would be that it would be better simply because if it's uneventful cataract surgery, the pressure goes down in people after cataract surgery. However, the people in the OAT study that Steve talked about did not have pseudoexfoliation.
It's specific for exfoliation.
Yeah, I don't know.
Okay.
Yeah, these are all patients.
Yeah, Dr. Allen.
Yeah.
In your study, you compared in the various groups with CTR, without CTR, single piece, three piece IOLs. was this criteria also there, the size of capsulorhexis, because the significant number of patients have post-operative period, like you showed in your study, after 1 year period, there was significant increase in capsular phimosis. Would size of capsulorhexis during primary surgery make an impact on decreasing the incidence of capsular phimosis at 1 year period?
That's an excellent question, and we don't have an answer to that. Our study did look at the size. The surgeons were all excellent surgeons at Arvin, all doing about 4 to 5 millimeter capsulorhexis. My guess is that it's not like flax where you can actually measure the size of a rhexis. We did not measure the size of rhexis, so I don't know the answer to that.
Because some surgeons, I found that what they do is that after doing surgery, after completing the surgery, they give a nick in the anterior capsule, so that somehow tends to decrease the incidence of capsular phimosis.
Yeah, we did not do that, and I think the lesson that we learned from this was that not only does the CTR not matter, nor the type of IOL, 1-piece versus 3-piece, but if you make too small of a rhexis, it may, and if it's not centered correctly, that could make a difference long term.
Dr. Bhalla, actually in these patients, making a slightly bigger rhexis, 6 millimeter rhexis, makes surgery also easier, because the capsule, we know the zonules are weak. So a larger rhexis helps the surgery also, and capsular phimosis is much lesser.
It is much lesser. Yeah, I'd just like to add regarding the pregnancy question that the American Glaucoma Society published a paper on ophthalmic drugs in pregnancy. It's in Ophthalmology Glaucoma, either last year or the year before, and it's open access, so it's free. So it's the American Glaucoma Society statement.
No, it's Dr. Purvi. I'm just asking Dr. Purvi, because you very nicely showed various adverse reactions of those medications. So is there any difference for the audience to use with, should they consider the preservative in that, or preservative-free medicine? So is there any difference, or is that any preference the doctor should give while prescribing medicines?
There are a few select cases where we can on the first go consider for preservative-free formulations. Some of them are like the patient inherently has an ocular surface disease. They already have significant dry eye or an ocular surface problem. Those are the cases where we can consider preservative-free formulations. Then entity is, which is known as pseudo-exfoliation, because again those are the cases where an inherent dry eye is already there. And young patients, those who are like computer workers and those who already have an exposure or an increased risk of dry eyes and ocular surface problems. Women of the menopausal age or who are in hormonal therapy, means all those risk factors which are there, which can put the patient at a higher risk for ocular surface disease or dry eye, there we can consider a primary preservative-free therapy.
Then if it is useful for those who are at higher risk, then why not give it to all?
To all, yeah.
Yes, we can consider, but again we have to consider the cost ratio, because there is a difference in the cost when we consider a BAK for containing formulation and a BAK free formulation. So
but if cost is not the factor, would we consider using preservative free formulations in all our patients?
Yes, definitely yes. Yes, ma'am. Yes, yes.
A lot about drug lots of side effects. What are the systemic drugs that we must take a history before prescribing these drugs? With them we have interaction with anti-glaucoma medications.
There are no known or established reactions which are there with anti-glaucoma medications, but overall, in general, a drug history is mandatory, because we do not know, because if a reaction happens, we need to keep that profile in mind.
Yeah.
So in general, overall medical history, what drugs the patient is using, especially like if we're talking of brimonidine. So if a patient is on MAO inhibitors, monoamine oxidase inhibitors, if a patient is on tricyclic antidepressants, any psychotics, so in those cases, we should avoid giving brimonidine.
So this is what I wanted audience for you to bring it out to them. Right, thanks.
Okay, yeah.
Can I? Preservative-free formulations, the unit dose formulations are practically unavailable in India for glaucoma. So all the preservative formulations that we speak of are these newer bottles, Novelia bottles, Aptar bottles. But then you search for literature about the use of these medications, you hardly find anything about the efficacy of this particular medication. Even if you go into the manufacturer website, they say that, I couldn't find anything. So are these actually effective? Is there any evidence that these medications do make a difference? The ones which are sold in India, that's what I wanted to know. Yes, from IOP and in terms of preservative free.
I think very rightly pointed out that these preservative-free are without side effects, but are the effects equivalent to drugs with preservative? Because preservatives are a necessary evil. We need preservatives to have good penetration also, good intraocular penetration, which will cause.
Yeah.
So if we are decreasing the side effects, are we not decreasing the effects also?
No, actually, some studies have been done. Actually, when Latoprost was first launched as a preservative-free formulation, those initial studies were there which compared the preservative-free. That was initially, to be clear, precisely speaking, it is non-BAK and BAK containing drugs. And there are recently, we also have at our place, we have done a study wherein we have compared the side effects and the patient tolerance and the rating for the drugs that they use which are BAK containing and non-BAK containing. So the efficacy, considering the IOP point of view, it is the same, and the tolerability and acceptance is much more. So studies have been there, yeah.
Is there time for another question, please?
Yes.
Yeah, some drugs, they're increasing the back to increase the efficacy and lowering the drug actually. So that is another point that everybody needs to take home, that there are some formulations in the market where the back has been increased and the drug dosage has been reduced to increase the penetration, and it's being marketed in a big way. No names here because the company is this thing, but all the same, I think this is another point.
Yeah, so I just wanted to ask to the House about normal tension glaucoma, and to Mr. Ansari as well. That was a lovely talk, thank you. About normal tension glaucoma, we have heard about the protective role of brimonidine as neuroprotective. What's the take of the House on beta blockers? In my personal experience, if someone is worsening and they're already in beta blockers, I do tend to stop them. But otherwise, I don't look into it too much. And there's been a debate in all glaucoma meetings that I go to about beta blockers and NTGs. So any comments will be most welcome.
No, I think Dr. Sanjay had answered that brimonidine is, he's coming.
Regarding the question about beta blockers, thankfully the beta blockers are not effective at night time. And we don't want the blood pressure to drop at night. So thankfully, since they're not as effective at night time, I feel it is okay to use a beta blocker. However, if the patient is severely hypotensive, my second drug of choice is a carbonic anhydrase inhibitor after prostaglandin.
Yeah.
And then if that doesn't control it and their blood pressure is not dropping too much, then I will use a combination drug. But brimonidine, I will typically not use. Of course, there is that controversy of the LOGIS study.
Yeah, okay. No, I agree. Thank you.
Yeah. No, so it's basically, okay, yeah.
Sir, one last question to you. We're just talking about this sleep apnea thing. And for example, we've done a sleep apnea study. He's having a sleep apnea. And we've done the CPAP titration, started him on therapy. Have you seen such patients' progression being arrested in your practice?
Unfortunately, the treatment of sleep apnea by CPAP does not halt the progression of the glaucoma. That has been shown in a study about 10 years ago. So this prevents their heart from failing, but unfortunately we have to become more aggressive in their glaucoma management, because CPAP does not halt the progression, actually worsens glaucoma progression.
Then Professor Steve, I think last question because we are finishing now time, that these days we are talking a lot about in the market the virtual reality perimeters. So what is your take on that, especially to judge progression in glaucoma patients?
Yeah, virtual perimeters are super convenient. You don't need you can just put it in the room with the patient. In some ways they just push a button when they're done, they go to the other eye. They can be pretty fast. We've done a couple, we demoed one type of virtual perimeter, and in the United States, I think there's like 8 companies right now, maybe 10, that are maybe more, that are trying to put together virtual perimeters for the marketplace. They're cheap. Visual field in the U.S. probably costs about $32,000. These cost about $6,000 to $8,000. So there's all these advantages. The issues that we have is that, it's complicated, but the way they present the images can sometimes be different than when we get to visual fields, and it's not sure that you can do a white-on-white visual field with a regular perimeter, and that can be transferred to one of these virtual perimeters. So I think it's a technology that's going to be more prevalent in the future, and we may do all of our visual fields virtually in the future or with these head-mounted perimeters, but right now they're just not comparable to the regular perimeters.
We're working with two companies now out of the many. One is Indian and one is an American company. We're trying, none of the perimeters now have been validated. It's nice to have a black and white printout that looks sort of good, but you really, when I was part of the CETA validation study, and so it was a really, Anders Hale really did a fantastic job of validating the perimeter. These aren't validated yet. So I think in the future they will be, but right now I wouldn't even waste $3,000 on it because they're not valid. You want to make sure you know what you're getting, so to speak.
So it means that right now the virtual perimeter means it's not the thing which can be incorporated in glaucoma practice right now as of the development of technology today.
Oh, I think the
only, but that has no role, only screening.
I think.
Yeah, okay, Sanjay.
I think for the patient who can't sit in a bowl or can't, isn't able to come into the clinic or something, it's ideal. We still don't know how to interpret the data, but it's ideal. Sanjay?
So we have a perimeter made by All Eyes. I have no financial interest with this. It's a head-mounted virtual reality set perimeter. The biggest use we found was patients who otherwise we would never have been able to get a visual field, like a patient who has a -7 diopters of astigmatism, doesn't wear contact lenses. We can't even put that in front of the perimeter. Whereas with this perimeter, they can keep their glasses on and the virtual reality headset goes on top of it. So we were able to get a visual field for the first time in somebody like that. Somebody who has a severe neck problem is not able to lean into that machine. And always we used to get our rim artifacts, lid artifacts. Suddenly we managed to get a visual field that was reliable. So there are some cases, okay, it's not easy to, as Alan said, we don't have any validation as to whether they are useful in monitoring progression, but you get a general idea if it's getting worse, what is the extent of the loss, things like that.
So it means it's as of today, it can only supplement. Someone has got enough money, can have both, and on those difficult situations that you described just now, it can help in that. So it has very limited role. Yeah, so thank you very much for this, all the speakers. I thank the chairpersons and the audience. And Sanjay, just one comment he made while he was talking, that so many people after a lovely lunch. So I think we should take a clue from this and we should stop providing lunch to the I'm just joking. Thank you.
The next session chairs can please come up in the meanwhile.